to understand what is the dimensions, who is affected, where they are. So what we did was set up the Jamaica Injury Surveillance System. How it works is that the patient comes into accident and emergency department. They're seen by the triage nurse or doctor, and there is a decision made as to the fact that it is an injury and that what type of injury it is. And then the patient is sent with a provisional diagnosis to the medical records team, who then collect the information on that injured patient according to the type of injury. So the triage nurse or doctor might have said it was a work-related injury. They might have said it was a motor vehicle crash. They might have said it was an unintentional injury. They might have said it was an attempted suicide. Or in the area that we're looking at today, they might have said it was a violence-related injury. Once it's a violence-related injury, the medical records clerk collects data on the circumstance. What was it? Was it a fight? Was it a gang-related issue? What exactly was the circumstance involving it? The next thing they asked was the victim-perpetrator relationship. The victim-perpetrator relationship has to do with the fact, is it a boyfriend-girlfriend based problem? Is it just an acquaintance problem? Is it a stranger? The place of occurrence, where did it actually happen? Was it on the street? Was it at home? Was it in a school? Was it in a workplace? What was the method of injury? Was it blunt force? Was it actually a stabbing injury? Or was it a gunshot wound? These sort of things. And we also asked whether or not the physician can determine whether the person appeared to have been under the influence. So this injury surveillance system has now been implemented in 9 of our major computerized hospitals. We started the program in 1999 at KPH, which is our largest trauma hospital located in downtown Kingston. In 2000, when we had sort of streamlined the program and refined it, we expanded the program to Conroe Regional Hospital, Maypen Hospital, Mandeville Hospital, St. Anne's Bay Hospital. And in 2001, we went to Spanish Town Hospital, Bustamante Children's Hospital, Savlar Hospital, and Annotto Bay. This data, and it has been written up in West Indian Medical Journal, is giving us information on 70% of the admitted patients to hospitals across Jamaica. So, as we said before, this is the kind of data: the date of the violence-related injury, the place of occurrence, whether it's home, school, work, the method of injury, whether it's a gunshot, sharp object, blunt object, the circumstance of the injury, whether it was a fight or a robbery, victim-perpetrator relationship, girlfriend, boyfriend, and very importantly, we collect information on the geographic occurrence of the injury. We take the geographic occurrence, the exact location, if we can get the street name and number and address, or the nearest intersection, or the nearest district. We use geographic information systems, and our program that we set up was called Health GIS. And what you can see is, looking at the data that was collected from Kingston Public Hospital, we were able to identify the areas in the communities that were most affected by violence. So the areas that are in deep red would be the areas where most of the cases that came into accident and emergency actually originated from. And this was done to pinpoint us if we have limited resources and we want to have a maximum impact on reducing the workload from violence-related injuries in the hospital. We have to put our intervention programs into those communities and reduce the amount of violence in those communities. So I'll give you an example of one community in Kingston where we have done even further analysis. and taken the data from the hospital and put it with other data on the community. What we do is actually collect information on the assets that are in the community. So this community, which is called Rosetown, we're actually collecting data as to whether there are agricultural areas in the community, whether there are community facilities, whether there are any manufacturing or industrial activities, any retail services, any retail shops, any vacant buildings. We also collect information on fire hydrants, street lights, whether the street lights are working or not working, and we collect information on derelict buildings. Data is then taken and overlaid with data from the police and from data from the hospital to give us an idea of how we approach and what areas of the community we are going to approach with what types of intervention. Then we take that data and we work with other agencies to get them to look at the data and to decide how all the different agencies can have an impact on the violence in the community. So we work with Ministry of Education, we work with the UN agencies, the music and the media industry, the University of the West Indies, the private sector, NGOs, church groups, ministries of national security, and even ministries of transport. All of them use the data, look at the data, and identify how we can use that data through the joint work of the Violence Prevention Alliance to see how together we can reduce the level of violence at the community.